So my topic is approach to vision loss. So the eternal questions in neurology. Is there a lesion? If so, where is the lesion? What is the lesion? So when we come to the history of vision loss, the first thing and foremost is you have to say whether is there an actual vision loss or not. For that, we ask you to do something called a best corrected visual activity. So best corrected visual activity actually gets rid of your refractive errors, mirror disturbances, and it actually forms a standard point of reference for your baseline investigations and your follow-up also. If you don't have a best corrected visual activity or ophthalmologist, you can always do a pinhole. Next important thing in your examination is your visual fields. All of you have seen this diagram, which you have been seeing since your MBBS days. Each and every type of visual field will help you localizing where is the vision loss. It can be complete, it can be sectoral, it can be homonymous vision field loss. The next thing is the color vision. It is one of the earliest signs that you will get in your optic neuropathies. As you see, blue and yellow loss is more in retinal pathologies as compared to red and green in optic neuropathies. Pupils, as I always say, pupils are your windows to your brain, and the only part of the brain that is actually visible to your for examination is the optic nerve head disc. You always look at the size, shape, and reactivity. RAPD is a very important clinical finding that you not to miss in your clinical practice. Fundus examination is a very difficult topic. I always tell my residents, you have to see 1,000 normal funduses before you say this is an abnormal fundus. Why I say so? Look at this example. A 35-year-old female with a history of migraine for the last 20 years, presents a blurring of vision for the last 2 years. This is your fundus, and the MRI is also showing a partially empty cella. Now, I see this imaging and say, yes, there's definitely disc edema. I want to see this in this patient for a CSF pressure examination. I want to rule out the idiopathic intracranial hypertension. I send this to my ophthalmologist to get a visual field and visual acuity before I do this. He sends me this picture back. This is an autofluorescence showing an optic nerve drusen. So this is not an optic disc edema or a papilledema. This is a pseudodisc edema. These are the various causes of a pseudodisc edema that you can see. The next case is a elderly male patient with chronic vision loss for 20 years. He has family history of vision loss. There's hearing loss. I look at this fundus. I say, oh, there is bilateral optic atrophy. This is definitely some Leber's or associated mitochondrial disorders. I send this to my ophthalmology colleague. He sends me back again this picture. He said this is lattice and cone dystrophy of retina. This is not mitochondrial. So first, what I say from this issue is that you always have to get your expert's opinion. Practice of neuro-ophthalmology is not by the neurologist alone. You have to bring in your neuro-ophthalmology colleagues also to get your things straight. So when do you decide this patient has optic neuropathy or this patient has maculopathy or retinopathy? When do you refer these patients to your ophthalmologist colleagues, or when your ophthalmology colleagues refer them back to you? So optic neuropathy is when you have a patient has vision loss. The actual graying or loss of vision happens in the particularly optic neuropathies. Whereas in macular disorders, you will have metamorphosis. The patient will say, I'm having distortion of the fields. Things are appearing bigger, things are being smaller. Retinopathy, you'll have light changes, you have photopsias going on. Vision loss is far greater in optic neuropathies as compared with your macular retinopathy. Color vision, red and green is involved in optic neuropathy, blue and yellow in the retinal. Visual fields are variable in optic neuropathies, but in macula, you have the predominantly central vision, whereas in the retinal involvement, you can see the peripheral constriction going on till you have a central field of vision only left in the vision. RAPD is a hallmark of optic neuropathies, very rarely seen in severe retinopathies. VPs in an investigation can point you towards an optic neuropathy or is optic of the visual tract. ERGs go in more in favor of maculopathy or retinopathy. So neuro-ophthalmic history has to be very precise and help you in reaching the localization of your lesion. First of all, you have to ask the patient, is it monocular or binocular? Is it transient or is it persistent? Is it acute, subacute, or chronic? Is there any associative fluctuations with those? And what are the associated symptoms? Are there pain? Are there diplopia? Is there proptosis? Are there any other neurological features associated which will help you in localizing these patients? So, coming into this first case, you have an elderly male, hypertensive smoker. He comes with intermittent blurring of vision in the right eye. When you see him in the OPD, you say vision is normal, 6/6. The fundus, the best corrected visuality, pupils, everything is normal. You send him to the ophthalmologist, so please let us see what is there. He comes back to you after 1 week with complete vision loss in the right eye. Now there's PL negative in the right eye, there's right-sided RPD, and the fundus shows a disc edema with hemorrhages on it. This is a flame-shaped hemorrhages. This is a vascular event. When you do an angio in this patient, there's a complete IC involvement. The patient also had carotid bruit, which we missed. So why I'm saying transient monocular vision loss, these are red herrings. These patients are actually giving you time before the diagnosis, before you lose these patients' vision once and for all. Vascular lesions, vascular loss of vision is very difficult to get back once that happens. So when a patient actually comes to you with altitudinal or lateralized homonymous vision loss, always think of an emboliform event, like a embolus from the carotid plaque, aortic arch, atheromas, or a cardioembolic stroke. These are emboliform inverse, which are involving the central retinal arteries. When you have diffuse graying of visual fields, the entire field is graying out, then you say this is a global ocular hypoperfusion. This ocular hypoperfusion is always involves the common carotids, where you have both internal and external carotid arteries, both are getting involved. So you have global hypoperfusion. This can be seen in carotid stenosis, giant cell arteritis, or ocular ischemic syndrome, which the first patient had. When you have constricting visual fields in the transient vision loss, it means the choroid is getting hyperperfused. The retinal part, the retinal part of the choroid is getting hyperperfused. This can be seen in giant cell arteritis or some forms of migraine also. So coming on to the these are the type of patients which you are going to see nowadays much more and often. Young female presenting with history of headaches for the last 6 months, complaints of intermittent blurring of vision. Patient will never tell you what is the type of blurring. I'm not having central vision, peripheral vision. The patient will just come to you intermittent blurring of vision. It's you who has to break up and make up this history. What is the type of transient visual obscuration is this patient now? She's complaining of both eye vision loss whenever she gets up from the sitting position and when she bends down. And for the last 1 year, she is having acute vision loss completely. When we examine her, she's obese, she has a best corrected visual acuity in one eye in 6/6, and pupils are sluggish. This is her fundus, this shows gross papillary edema, and there is some formation of macular star also. The MRI is showing tortuous optic nerves, partial empty cella, and we did the CSF, yes, it's very high, it is independent intraocular hypertension. So it's basically optic nerve head hypoperfusion, which was causing this transient visual obscurations. These are not only a sign qua non of papillary edema, this can also be seen in optic nerve, optic disc drusense, and congenital anomalies of disc, where you have loss of vascular supply during the transient changes in your blood pressure. So this is not the end of the story. We investigated this patient further. She had an HB of 5. Her ferritin was low, undetectable. I gave her 2-pint RBCs just to get her ready for the ONSF. Within 2 days, her visual field improved. She was basically raised intracranial pressure, second to significant iron deficiency anemia. So the same patient, if this same middle-aged patient comes to you with headaches for 6 months, sudden onset bilateral vision loss, but this time the fundus is normal, pupils are normal. So that means this is something in the posterior. So this is bilateral PCA territory infarct secondary to RCVS. So from this, I am to conclude what is the difference between anterior and the posterior visual pathway. What is the anterior visual pathway? What is posterior visual pathway? If I say, if you are sitting in the next hall in the neurosurgery department, they'll say everything beyond the optic chiasma is posterior visual pathway. But you are sitting here in the neurologist. For a neurologist, the lateral geniculate body is the hallmark defining between anterior versus the posterior. How do you say in history is it anterior? Anterior visual pathway, most of the time the vision loss is unilateral much more than bilateral. Yes, there are exceptions to this. Severity of vision loss will be much more than in the posterior visual. Symptoms like color desaturation, retrobulbar pain, examination findings like field effects, RPDs, disc edemas, these all point towards the anterior visual pathway. Posterior visual pathway, like cortical vision loss, patient hardly will complain to you that I have vision loss. They may just they might have denial of blindness, they might just bump into objects. And of course, you have cortical signs going along with it. So when you have localized, this is anterior visual pathway, next thing is you have to order the specific investigations. This is a routine patients which you get young female presents with painful eye movements followed blurring of vision. You examine her vision is 6/36. There's a right-sided RPD. Clinically, you say, yeah, this is optic neuritis. But she comes to you with this MRI. With the MRI report is saying MRI brain plus orbit is normal. No, you don't look at this MRI. This MRI is not a good MRI. The MRI of the orbits should have a fat suppressed image that you should ask for. The radiologist, you should ask the radiologist that I want a fat suppressed image, not a routine run of the mill MRI that you get every day. When you get a fat suppressed images, the optic nerves are glowing in this picture. You can see the entire right-sided optic nerve is glowing. She was NMO antibody positive. She was complex. She improved. So when you look at the demyelinating optic neuropathies, large number of these patients you may be able to diagnose based on the location of these lesions. The first, especially when the patient is presenting to you just with vision loss. Multiple sclerosis may have unilateral patchy involvement, small segments. Neuromyelitis optica will have chiasmal involvement. What you see in neuromyelitis optica is classically posteriorly extending longitudinal optic neuritis. This is a long segment of the optic nerve along with the chiasma is involving. MOG comes with bilateral severe vision loss, and in MOG you will have severe optic perineuritis also. This is a classical junctional scrotum of trachea when you have involvement of lesion is at the junction of the chiasma and the optic nerve. So whenever you have associated symptoms like redness, blurring of vision, you always thinking primary ophthalmic disorders. So in this case, we have a 65-year-old female CA breast survivor on chemotherapy, radiotherapy. She comes to you with the asymmetrical sequential vision loss, right followed by right. She has some pain in her eye movements. You see there are bilateral, the eyes are congested. The ophthalmologist sends this picture. Where is the optic disc? I can't see the optic disc. They say this ophthalmologist says she has bilateral BRVO. Then why are they sending this patient to me? Why am I seeing a patient of bilateral CRVO patient in my OPD? Because more than we have learned from the ophthalmologist, my ophthalmologists have learned more neurology. They say the pupils are not reacting. Why is the pupils not reacting? Yes, then I also say, yes, the pupils are not reacting. There must be some optic nerve pathologies. We get the MRI. She has significant. These are contrast enhancing images. The optic nerves are lighting up bilaterally. She has, apart from optic neuritis, you can see that optic nerve sheath is also bright. So what we are looking at, it is an optic perineuritis secondary to varicella zoster involvement. So how do you differentiate between perineuritis and neuritis? Neuritis is involvement of the optic nerve. Optic perineuritis is the inflammation of the nerve sheath. When you have involvement of the optic nerve, you just get the central scotomas. When you have involvement of the sheath, the scotomas comes from the periphery because the sheath is covering from your periphery. The onset of the associated pain and ophthalmic picture is much more in the perineuritis group of patients. If significant perineural involvement, there's spreading of inflammation around the structures also. An exception to this rule is MOG optic neuritis, in which you have significant optic neuritis and perineuritis also. So coming on to the course of disease, most of these diseases are very short. Some of these diseases can be very long. A young male presents with 4 weeks of painless progressive vision loss, sequential, left followed by right. I see this patient, there's a left-sided RAPD, this finger counting at this NMO MOG was an all negative, CS was normal. We got this MRI done. There is atrophic optic nerves. There is central scotomas. This patient is possibly Leber's. Now I follow this another patient with similar history, 1 year history, progressive vision loss. I say there's no toxin. This must be Leber's. But we get an MRI. This is a compressive optic neuropathy. Look at the difference between the fundus. There is significant bitemporal hemianopia and there's bitemporal pallor. So this is a patient of compressive optic neuropathy. So you have new challenges that are coming up. In COVID times, you have seen patients with significant vision loss, anterior visual pathway development. This patient presents to us with involvement of unilateral vision loss, painful ophthalmoplegia, and fifth V1 involvement. So we are looking at anterior cavernous sinus and the orbital apex involvement. So this is basically a patient of mucormycosis, which you are all dealing with. The cavernous sinus is a treasure trove of pathologies. Anything and everything can involve your cavernous sinuses. The differentials are as only limited by your imagination. So localization is not always easy. The cases when patients don't read books, nor the diseases read those books, you have to guess upon your own, you have to use your own experience. Young primary, 34-week presence of GT cells, followed by loss of vision. You see here, she has bilateral finger counting close to face. There's some disc edema, there's some hemorrhages, blood pressure is elevated, pupils are sluggishly reacting, but she also has an MRA of a press. So in your day-to-day case scenario, there'll be multiple localization. So this is a patient of press, she recovers completely within a week. Papilledema versus retinopathy, you have to distinguish. There is arterial narrowing in your hypertensive neuropathy. There are cotton wool spots. There are macular stars in hypertensive retinopathy, which are not seen in your papilledema. The classical hallmark that you can have to look for is the absence of spontaneous venous pulsations. It can be having multiple localization, yes. This is a patient which I saw a few years ago. This is an 18-year-old male present with drug abuse, headaches, and vision loss for 1 month. On examination, bilateral PL negative, pupils are non-reactive. Apart from the disc edema, we can also see there's some chorioretinitis also going on. Dr. R.K. Garg is very interested at this point of time. We see this patient had a significant necrosis of the inner nuclear layer of the retina, complete necrosis of the retina. And as we can see, what are these structures? These structures, there's involvement of the occipital cortex. These structures are nothing but the lateral geniculate body. This disease was ravishing the entire visual field, right from the optic retina till the optic tracts, lateral geniculate body, occipital lobe. This is SSPE. SSP is a disease of the brain which predominantly targets the visual system. So what is the role of a clinical assessment? You have to examine each patient clinically and communicate with your colleagues. This is a patient which was referred to us as a suspected athambutal toxicity. She was taking ATT. Despite stopping ATT, she was not regaining vision. On examination, the fundus was normal. Pupils were normal, but she was still denying people. We get her MRA repeated again. The radiologist says there are multiple tuberculomas. I don't see any optic neuritis. I don't see optic chiasmatic retinitis. I don't even see optic nerve atrophy also. But we said we are not looking at optic neuritis. This is a posterior visual pathway defect. We are looking at the cortical involvement. Then the radiologist said, then we have two occipital tuberculomas sitting at your occipital corpus. This is what you learn by talking with your colleagues in your radiology. Don't learn neurology isolation. Learn from your colleagues. So since the time is short, I'll be going through cortical vision loss. We will have intact pupillary reactions. Optic retinitis will be lost. A patient, this is a classical PCA territory infarct. Patient will come to you presenting with vision loss in the left eye. Now I have told you, posterior vision pathway is usually bilateral. When you have PCA infarct, there is vision loss in both fields. Why did the patient come to you with left eye vision loss? Remember, patients never read books. Patients, and neither. When you have vision loss in the posterior posterior visual pathway, remember you have one side nasal involvement and one side temporal involvement. When the patient is looking at towards in front of you, when the patient's nasal field goes, the temporal field opposite also goes. So the nasal field of the normal eye will always compensate for it. So the patient will only notice the temporal field of vision on the opposite side. That's why these patients will come to you with only one side vision loss. They'll never say, I have nasal field vision loss. They'll just see they'll only complain of temporal field vision in the involved side. I'll not go through this in the short run of time. You have alexia with the agraphia, which is classically on the left side, the visual word forming area involvement. Yes, this I'll try to take a few minutes. When you have, in this day and era of litigation and everything, there are patients who come to you with just functional vision loss. Now, in this litigatory era, how would you say this is not this is completely functional? I don't have 35, 40 years of experience. Just when a patient walks to you and say this is functional vision loss, this is not, say, optic neuritis or posterior circulation stroke. These are never a diagnosis of exclusion. You have to examine them closely. Every part of the vision system has been done. So you have to do all the gambit of investigations in these patients. Unilateral vision loss, bilateral vision loss. You have to do every possible that. You have to look at the examination, clinical examination, RAPD. The same thing which I explained in all my presentation is documentation of visual field, ERG, EMG. The most common test that we do in your OPD is use of an OKN. Most of you don't carry an OKN. Don't try to use that mobile version in which there's a moving app which doesn't do any good. Prisms can be a very good way of looking at refixation when the patient is having. Or the objective ways of documenting there's no abnormalities, you would do an objective VEP on ERG. If you don't have, you can use a mirror also. You can use a large mirror in which the patient, sudden shifting in front of the patient will induce a nystagmus if you don't have an OKM. So take home message is you always have to clinically examine the patient. You have to localize before you send the patient to your MRI. Localize, then you don't ask the radiologist to give you a localization. You give the localization to your radiologist, then send it. Multiple localizations are always known, and if you're in doubt, always go back in your review. And in the practice of neuro-ophthalmology, never learn in isolation. You always have to communicate with your friends in ophthalmology. You have to communicate with friends in radiology. You have to communicate with your neurosurgeons also. So with this, I like the time to invite you all for the next year's conference that you will be hosting in Chandigarh, the city beautiful. It has much less pollution compared to Delhi, and it has very beautiful environment also. And thank you. Thank you very much.